Welcome, Cardiology Update viewers and listeners. My name is Shadi Reis. I'm an interventional cardiologist at Detroit Medical Center in Detroit in the United States. As you know, we come to you every month with a summary and highlights from major meetings and also major publication in the realm of cardiology. This episode will be highlighting the ARTICA trial, and this is the rollout of non-ST elevation acute coronary syndrome by a single pre-hospital troponin measurement. And this randomized trial presented at a recent conference. And I'm really privileged today to be with one of the investigators from the Radboud University Medical Center in the Netherlands, Dr. Jaris Arts. Dr. Arts, thanks for being with us.
Thank you for having me.
So tell us a little bit about the rationale behind the ARTICA trial.
So, patients with chest pain are usually transported to the hospital. And we know that hospitals and more specifically the emergency departments are overcrowding nowadays. And this is a worldwide problem. However, the majority of patients with chest pain do not have an acute coronary syndrome. About 90% is discharged from the emergency department. And a few years ago, some studies have shown that ambulance paramedics are able to identify low-risk patients in the pre-hospital setting who are not likely to have an acute coronary syndrome. But there was no randomized study yet trying to rule out an acute coronary syndrome with pre-hospital risk assessment yet. So that's where the ARTICA trial came.
And this is a very important question, especially in the time and era now we have shortage with staff. And especially after COVID, I'm not sure of what's happening, the same thing in the Netherlands, but in the United States, the wait time to go to ER is longer, to get a bed in the hospital is longer because of a staffing issue that is kind of evolved after COVID. So this trial is timely and definitely increased efficiency. So what was the key question of the study?
The key question was, what is the impact of pre-hospital rule out of ACS on healthcare costs and safety?
Okay, and can you walk us through the design of the trial?
Yes, of course. In low-risk patients who were identified by ambulance paramedics in the pre-hospital setting, we performed randomization. And the low-risk patients were identified by assessment of the HEAR score, so the heart score without the troponin component, so history, EKG, age, and risk factors. And if the ambulance paramedics thought that the patient was a low-risk patient, then they were randomized to A, standard care, so transport to the hospital, or B, a point-of-care troponin measurement. And in case of low troponin value, then the care for the patient was transferred to the general practitioner.
Interesting. So this point of care, is it a standard of care or is it available with the EMS or the emergency response team?
No, it's not standard yet.
Okay, so, but it is available, any commercially available point of care. That's what had been used in the trial.
Yes, it's the point of care assay from Roche.
Oh, okay.
It's not high sensitivity, but yeah.
Yeah. So okay. So walk us through the main finding.
Well, the main findings, because of the primary outcome, which was healthcare costs, the main findings were a significant reduction in healthcare costs of around 600 euros per patient, which translates to a yearly cost reduction of 48 million euros in the Netherlands. Mm-hmm. And we're a small country.
Yeah, and this is focusing on the cost. How about in terms of the clinical outcomes? I think this was a secondary endpoint for the trial.
Yes, and it's one of the most important endpoints of the trial, I think, because that's what we all want to know. How safe is pre-hospital rule out? We saw that major adverse cardiac events occurred comparable between the two strategies, 3.9% versus 3.7%, including the patients who had an acute coronary syndrome which was diagnosed at home or at the ED. So we also looked at the patients who had a ruled out ACS at home with low point-of-care troponin or at the ED with standard procedures. And in these ruled out ACS populations, we found that the incidence of major adverse cardiac events in the first 30 days was very low, 0.5% versus 1%.
Interesting. So let me ask you this then, just to simplify to the audience. You do a test in the EMS, and if this test is negative, what is the protocol tell the healthcare provider to do? Just call the ER saying this is a low risk profile patient, and they cancel the transfer or admission to ER?
Well, yes, that's exactly what happened. So at first, they called the ER if the patient was already signed on to come there. And they called the general practitioner to tell the GP, okay, I have a patient, he or she does not have an ACS. Can you follow up?
Okay. And when you said a follow-up means follow up with the primary care or cardiologist that is set up just to check on the patient later on, correct?
Yes. And in many patients, it was only a phone call to the GP, and then the GP could decide whether the patient had to come or not.
That's very interesting. So this is I'm a very intriguing trial for sure. And as I said, it's increased efficiency, but also it shows some safety that you are not doing any harm by bringing the patient, doing the test in the ER, and then sometimes they get 6, 8, 9 hours in the ER waiting to have a test result coming back. This is quick and kind of triage the patient quickly. So where do you go from there? How do you think this protocol or this trial will be rolled out in a clinical practice?
Well, how can I say that? We hope that this protocol can be implemented in current practice. But like we talked about, it looks like it's safe, but our trial was not powered to show safety. Mm-hmm. So I think before we can perform implementation, we have to perform a randomized trial which will be powered for safety. But of course, with these low numbers of patients with MACE, we will need a lot of patients to really show non-inferiority for safety.
Yeah, but this is kind of a reassurance that doing that practice is not cost effective, number one, as you mentioned, but also can sometimes triage the patient the right way to see the primary care quickly and treated properly.
Yes, and it's over 90% of our patients in the pre-hospital strategy did not go to the hospital. So it's a lot of patients who are prevented from having to go to the hospital.
Right. I think, as you mentioned earlier, it might be not ready, as you mentioned, in terms of studying the efficacy as a safety, but implementation-wise, I think we have the point of care in the ER, we have the point of care in the hospital. Having one in the emergency response team kind of truck or car might be an easy implementation if this is rolled out broadly.
Yes, I agree. However, we do need to have a reassurance that the patient is not just ruled out and left to fend for themselves. So the accessibility of primary care is also essential.
Absolutely. Well, I'm really excited for this trial, and I think it's going to be changing practice. As you mentioned, we are scratching the surface in terms of studying the efficacy, but definitely follow-up required. But definitely this is take us in the right direction in terms of implementing new innovative way to better expedite care and also triage patient in the right way. I would like to congratulate you, Dr. Yaris, for your and your team and your co-investigator for putting this trial together. And hopefully we'll have more follow-up soon.
Thank you very much.
Thank you. Thank you all for watching us today. Again, this is Shadi Reyes from Cardiology Update. Stay tuned for more episodes every month. We're going to come to you every month with more update, either from conferences, as I mentioned, or from major publication. Watch it on all social media portals, YouTube, Facebook, Twitter, as well as Instagram. Again, I am Shadi Reyes from Detroit. Thank you for watching us.